Excellent. Thank you so much. I'm really happy to be here. I always love working with Wake Up Narcolepsy, such an amazing organization. And thank you guys for coming and for being interested in this thing that I care so much about, which is how sleep is related to heart health. So let me share my screen real quick. All right. So we're talking about hearts that never rest. So let me just get started. And as always, I have too many slides, but I can stick around a little bit for questions. Starting with some disclosures, I have some disclosures, but um, I'm not really talking so much about medications, and everything is based on citations that are here in the presentation. Sleep is related to health broadly. It's related to almost every domain of health that I could think of, whether it's metabolic, cardiovascular, immunologic, mental, behavioral, and cognitive health. All of these different domains, they're all separate. They all have separate pathways. They all relate to health outcomes in different ways, but they're all sort of boxes within this larger space that are all connected with each other, which is why it's drawn that way. Um, so, speaking about sleep and heart health, about 10, 15 years ago, the American Heart Association realized that focusing solely on cardiovascular disease was a little too late in the process. And instead, they needed to focus on what they were calling cardiovascular health. And to conceptualize cardiovascular health, they came up with a framework called Life Simple 7. And Life Simple 7 was their understanding of what are the components of health. And it included, let's see if I can remember them off the top of my head. You had diet, physical activity, fasting glucose, weight, lipids, blood pressure, and smoking. So those were the 7 dimensions. But over time, it became clear that the Life Simple 7 was never simple, and it shouldn't have been 7. And so very recently, this framework was updated, and now it is Life's Essential 8. And Life's Essential 8 is the new framework for understanding health. And as you can see, the original 7 are all there, but now number 8 is sleep health. Sleep is seen as an integral part of cardiovascular health. And furthermore, I should note that in addition to Life's Essential 8, we also have additions to the framework from the American Heart Association, including the role of psychological health in all of these 8 dimensions, as well as the upstream role of social determinants of health that dictate the context in which all of these things happen. So sleep is integral to heart health. I'm not going to present lots of data that shows you how and why sleep is linked to heart health. I've presented on that a bunch of times before. You could find some of that online. And B, I've got other stuff I want to talk about related to narcolepsy specifically, so we can talk about that. But if you have any questions, let me know. It's important to note, and as a psychologist, I feel the need to remind people that in the sleep world, you have a lot of the cardiovascular, more basic researchers focused on that question. And then you have the behavioral and mental health people focused on that question. But these are not separate questions. Sleep loss is related to both poor health and impaired brain function. And when I'm talking about sleep loss, in narcolepsy, when you're talking about sleep loss, it's more about unhealthy sleep patterns. And it's possible that these effects overlap. And many health conditions are made worse by increased stress and greater difficulty making healthy decisions, which are the cognitive and brain effects of disrupted sleep, not just the metabolic or hormonal effects. That these effects overlap with each other. And this is getting worse. So here's some data we published showing that at a population level, we're actually losing a little bit of sleep, especially among the Black and African American and Mexican Hispanic US communities. They're losing sleep faster than everybody else. And this is correlated with population level changes that we showed in this paper of obesity, prediabetes, and hypertension. So population level changes in sleep are dictating heart health. But what about narcolepsy? So here's a paper that just came out this past year, working with a group of colleagues along with some of the folks at Avadel that really got really interested in this, and they helped sort of push this forward. This idea of writing a paper that takes life's essential eight and puts it in the context of narcolepsy patients. And so a couple takeaways from this paper, and anyone who wants a copy, I'm happy to send you. Um, First of all, like, some of these issues with narcolepsy is that people with narcolepsy sometimes have a hard time eating better because feeling sleepy makes it harder to shop for healthy food, cook, and prepare meals. And so there might be more of a reliance on quicker and more easily accessible food sources. People with narcolepsy have a harder time managing weight because, they might crave more high calorie foods, and even some medications can increase nighttime eating. People with narcolepsy have a harder time being active because sleepiness and even cataplexy can make it hard to be out and active. And some treatments also reduce daytime activity levels. And it might be harder for people with narcolepsy to manage blood pressure, cholesterol, and fasting blood sugar because of some of the medication stuff and the lifestyle factors. Um, and a lot of people use tobacco as a stress reliever, but also to help stay awake. So maintaining heart health might be especially hard for people with narcolepsy. And that's why, so this is a figure from the paper where, as we talk about the eight, life's essential eight here, how do all of these relate to people with narcolepsy? And that each one of these is important for people with narcolepsy. And so I'll just leave this on for a second for people to see or take a screenshot, but I'm also happy to share this with anybody. Um, Also of note, one of the things we talk about is the medications for narcolepsy. Sometimes they can have cardiovascular related effects, like like stimulants can increase heart rate, and some of these things. And you have armodafinil that might have some issues with cardiovascular disease. Solriamfetol could have implications for heart health. Pitolisant also can be, you might want to watch out for some people with certain heart conditions. And the oxybates, especially the high sodium oxybates, and we're going to talk about this, might have blood pressure effects because of the sodium. Um, so this is a paper that also recently came out looking at people with narcolepsy versus matched controls who don't have narcolepsy, showing that they're at a higher risk for cardiovascular disease, major cardiac events, stroke, edema, and AFib, especially including each of those separately, heart failure, ischemic stroke, and myocardial infarction. When they looked at within those, so this is for cardiovascular disease, showing that it impacts all age groups. It impacts men and women. It's people with and without sleep apnea. So what you can see is people with narcolepsy are more likely to have cardiovascular disease, irrespective of these other conditions, including which type of narcolepsy you have. Same thing with major cardiovascular events like a stroke or something like that. It wasn't associated in people under 25 because those events are so rare. You can see the super wide confidence intervals there. But it seems to be to impact people across the age and demographic spectrum. Same thing with stroke. Narcolepsy increases the likelihood of someone having a stroke, irrespective of whether or not you also have sleep apnea. It's not about those things. It's not about whether or not you have diabetes or hypertension or whether it's narcolepsy type 1 or type 2. It can change the risk, but it doesn't change that there's a risk. So I think this is really important. This was another paper that came out sort of recently, and this is tracking people over time. So what you can see on the x-axis is time since follow-up, and the lines drop as people get conditions. So the blue line is hypertension. So the solid blue line at the top are people who don't have narcolepsy, and the line on the bottom is people who do have narcolepsy. And what you can see is the people who do have narcolepsy, that line is dropping faster. That's the blue line. um, the people with narcolepsy are developing more hypertension earlier and faster. The red line is high cholesterol. And as you can see, the people with narcolepsy, their line is dropping further and faster. Even early on, even like earlier in adulthood, you're still getting higher blood pressure, higher cholesterol in people who have narcolepsy versus people who don't. And on the top is stroke and other, or well, top not stroke, the top is diabetes. And you can see again over time, people with narcolepsy are developing more type 2 diabetes than people who don't have narcolepsy. That line is dropping further and faster. So, what might be going on? So, you have narcolepsy, and then you have orexinergic deficiencies. So, part of narcolepsy, one of the contributors to cardiovascular disease might be orexin related. But also, you have excessive daytime sleepiness, which is separate from the orexin system, which itself might be a contributor to cardiovascular disease. And in addition, you have disturbed nighttime sleep. That itself can be a contributor to cardiovascular disease, separate from these other factors. And then you also have the comorbidities. People with narcolepsy are more likely to have other conditions, and those conditions themselves might also become a narcolepsy risk factor. So, so first let's talk about some of these orexinergic deficiencies, and then we'll talk about daytime sleepiness, and then we'll talk about nighttime sleep, and then the comorbidities. Well, actually, so in terms of these comorbidities, um, narcolepsy itself, might lead to some of these things, like I was saying. But there's a wide range of other conditions that people with narcolepsy are more likely to have, whether it's mental and behavioral health conditions, endocrine, sleep-wake disorders, and other conditions that could all be related to increased cardiovascular disease. So it could go through those things. So a little bit about the poor sleep health. If you have insomnia, people with narcolepsy can have more insomnia, or just poor sleep health in general, which is associated with elevated likelihood of obesity, diabetes, heart attack, coronary artery disease, and stroke. People with poor sleep quality are 30% less likely to have successful weight loss. So it's harder for them to lose weight. Um, People with poor sleep quality or sleep continuity disturbance, where their sleep is broken up, they're more likely to develop hypertension. They're more likely to have uncontrolled HbA1c, indicating diabetes risk. Sleep apnea. There's a lot of overlap between sleep apnea and narcolepsy, and in particular, people with sleep apnea, they have more cortical activation, more upper airway obstruction. All of these different things you can see in the image are different ways that having sleep apnea can impact heart health. And all of these become more likely, not just because of the narcolepsy, but because narcolepsy is linked with sleep apnea, the sleep apnea itself. Um, so the autonomic nervous system regulates a lot of restorative and recuperative functions in the body. It regulates things like your heart rate, your respiration rate, your metabolism, and your stress responses. Um, and it's broken up into two different components. You have the sympathetic nervous system and the parasympathetic nervous system, where the sympathetic activation increases cardiovascular risk. It's focused on action, sort of a fight or flight sort of response to sympathetic activation. Then you have parasympathetic activity, which is more associated with relaxation and recovery. Um, and what has been shown in a number of studies now, that autonomic function itself fluctuates across 24 hours and is related to sleep quality. And when you have more frequently interrupted sleep, you can alter your normal autonomic patterns across 24 hours. And so what you can see is, so on the right, you see in particular what happens to blood pressure. Blood pressure is supposed to dip at night. And what you can see is it's dipping less in people with more disturbed sleep. And so orexinergic deficiency, and why am I talking about this? Orexinergic deficiency is associated with elevated sympathetic activation and non-dipping patterns. So what that means is people with orexin deficiencies may have more sympathetic activation in that fight or flight system anyway, which leads to more cardiovascular risk on its own, but it also is associated with less nighttime dipping of things like heart rate and blood pressure, which is also decreased recovery and cardioprotection, which is supposed to be happening at night. So that's why I'm talking about autonomic nervous system. Here's another study that recently came out showing a stress response in people with narcolepsy to people without narcolepsy. And what you can see is, so time point T1 is like during the point of stress, and then you have the recovery period afterwards. And what you can see is people overall with narcolepsy, they have a stronger stress response on average. It's not, the effects aren't gigantic, but they're definitely noticeable and definitely there. Where biologically they're responding to stress more. And then on the right hand side, it's their sort of reports. VAS stands for Visual Analog Scale. So they're rating. Um, they had more stress, more anxiety, more insecurity, more perspiration, more sleepiness, obviously, and lower energy levels than controls under a stressful condition. So, again, here's more evidence showing that people with narcolepsy not only might have a heightened sympathetic nervous system, that may be part of what's going on in terms of they react to stress differently, which can contribute to cardiovascular health. There are orexin terminals and orexin receptors in all regions that are known to regulate cardiovascular function. We don't know tons about this yet. The orexin system does directly connect to several pathways in the autonomic nervous system. That might be why these things exist. It seems to play an important role in stress-induced hypertension, just like that study was showing that your body reacts a little more. Um, but blocking orexin doesn't seem to lead to lower blood pressure, just blunted 24-hour patterns. So here's another study that laid out potential pathways linking narcolepsy with metabolic syndrome, not just cardiovascular disease, but how metabolism relates with cardiovascular disease, where narcolepsy has not only that orexin deficiency that I just talked about at the top, but also hypersomnolence, as well as decreased sympathetic tone, changes in eating behavior, it decreased leptin and increased leptin resistance, which is a metabolic thing, um, and which can lead to weight gain and obesity through also partially not just through the orexin system and sleepiness and decreased energy, but also through some of these other physiological pathways. There's still very little scientific work looking at links between narcolepsy and mental health. It's despite countless patient reports that narcolepsy significantly impacts mental well-being in many ways, and the stigma of narcolepsy is specifically a major source of stress. And this paper, I think, spells out that a big part of this has to do with stigma, that the perceived stigma of narcolepsy not only um, impacts uh, levels of depression, which itself leads to decreased functioning. But the degree of perceived stigma actually accounts for some of the relationship between the sleepiness itself and the decreased functioning. So for people with narcolepsy, it's not just that there's increased sleepiness, which impairs your functioning, which many people will say like, well, that's sort of the elephant in the room. But what this is showing is that when you're sleepy a lot, it impacts your perception of yourself and how other people perceive you, which itself is an extra burden, which impacts the functioning. So some of the way that sleepiness impacts functioning isn't just the sleepiness, it's how you're reacting to the sleepiness, where it creates these extra burdens. So, which will lead to difficulties with daytime functioning and health-related quality of life. Um, the relationship between insomnia and depression is one of the most well-established in all of sleep research, and it's associated with every single symptom. So here's a study we did a bunch of years ago showing that in a community sample, people who say that they're having trouble sleeping at night, having trouble with day, and the blue bar though is important because that's daytime functioning. Those are people who say their sleep problems are interfering with their daytime functioning, and the yellow bar is also important because that's people who are saying they're satisfied with their sleep and they're stressed about their sleep. People who are dissatisfied and stressed about their sleep and for whom sleep impacts their daytime functioning, it's going to contribute to depression more than the not sleeping part of insomnia contributes to depression. And I think that's important because these are things that people with narcolepsy are experiencing. They're experiencing daytime functioning problems because of sleep, and they're experiencing stress and dissatisfaction about their sleep, which is impacting on their mental health. There's been over 30 studies now showing that people with narcolepsy have reduced health-related quality of life which impacts functioning in a lot of different ways. Um, and if you look at this, it impacts lots of different domains of functioning in terms of just somatic, as well as social, as well as energy level. And so, I mean, one of the reasons for this is, so here's a slide I've presented before, but I think it's really important because, like, this isn't a study I'm citing, it's just an observation that if you actually look at what the experience of depression is, and then you look at what the experience of narcolepsy is, you see these overlaps. So, like with depression, you have debilitating fatigue and lack of energy. That sounds very familiar to narcolepsy patients. Part of depression is disturbed sleep and difficulty maintaining sleep, right? Well, that's something that a lot of narcolepsy patients experience. Part of depression is delusional beliefs about like the future and things being hopeless and like, some of these exaggerated ways of seeing the world. But in narcolepsy, you also have distorted perceptions of reality sometimes that are just part of the condition that you just have to deal with. In depression, you have psychomotor problems, which is either slowing because your body is just burdened, or you become fidgety. Um, and you get psychomotor issues in narcolepsy too. In depression and in narcolepsy, you have problems with work and school performance as a key part of the condition. In depression, you feel very isolated. You start withdrawing from other people. That sounds very familiar to a lot of narcolepsy patients. In depression, you get appetite dysregulation, which is also not unfamiliar to narcolepsy patients. In depression, things can feel very hopeless. It can feel like whatever it is you do, you can never get to where you're trying to go, and things just seem kind of hopeless and uphill all the time. That sounds very familiar to narcolepsy patients. There's a lot of guilt in depression, even a lot of unnecessary guilt where you feel burdened by all kinds of responsibilities that are outside of your control, but yet you still feel guilty for them. That sounds very familiar to a lot of narcolepsy patients. People in depression are often perceived as being lazy. It's like, well, you just got to get over it. Why can't you just suck it up and do what you need to do? This condition you have, I can't see it. Whenever I've felt similar to how you describe, I just sort of, get over it and start moving. You must be lazy. That's why you can't accomplish all of these things. That sounds very familiar to narcolepsy patients. Well, I've been tired and I just suck it up and do it. Like, you know, and when you look at this, and just as a psychologist speaking, you look at what is depression and you look at what is it that people with narcolepsy face every day, then you say, well, no wonder why there's a huge overlap. But then once you have depression, that adds a whole other extra burdens on there. There is one study from a bunch of years ago showing that people with narcolepsy are much more likely to experience a lot of psychiatric issues compared to the general population. Is it because of a common pathway? Is it because, the narcolepsy itself? Like, look at agoraphobia. Agoraphobia is where it's sort of like the opposite of claustrophobia, where claustrophobic people, like, they can't be in contained spaces. Agoraphobic people, they don't like being exposed. They don't like being in an unfamiliar place or out in the world because they feel untethered. They feel very unsafe. Not because they think anything's going to happen, but because it's uncomfortable. Well, people with cataplexy report this all the time, or people who aren't sure when they're going to need to sleep. It can be very distressing. It's sort of like, when somebody has a small bladder and they need to always find a bathroom, it can be very stressful to, say, travel on a bus or a plane or go to work all day if you don't have ready access to these things. People with narcolepsy worry about being outside of a place where they can do what they need to do. So, like, they have a lot of these sorts of issues. There's also overlapping medications. A lot of the medications used to treat narcolepsy are the same medications used to treat a lot of other psychiatric conditions, including antidepressants and antipsychotic medications. Speaking of medications, that's going to be my very subtle segue to talk about sodium. So sodium is a problem in narcolepsy treatment. Sodium oxybate is well studied and effective treatment for narcolepsy. But there is a problem in that it has very high levels of sodium. Sodium intake is associated with higher blood pressure, increased vascular resistance, as well as increased arterial stiffness and fluid retention. I mean, there's a whole pathway here involved in this, where high sodium intake can impact things like blood pressure, and that can be an important cardiovascular outcome. So poor sleep health is also associated with higher blood pressure. Talked about this, including narcolepsy itself is associated with higher blood pressure. So, and also, it's been known that reducing salt intake could prevent cardiovascular disease. So, here's some data on cardiovascular number. So this is number of prevented incident cases of cardiovascular disease associated with decreasing salt intake, and showing that like the more you can decrease salt intake, you can prevent heart disease and strokes in adults. This is a known population health thing. So part of this is this trade-off of, while narcolepsy and poor sleep itself is such a cardiovascular risk factor, a little extra sodium intake may or may not, you know, be, you're weighing the risks and benefits. The benefit of the treatment might outweigh the additional risk. But is there additional risk? And it looks like there is. And so here's a paper that just came out this past year where they looked at high versus low sodium oxybate on blood pressure in narcolepsy patients. And when they switch people from high sodium oxybate to low sodium oxybate, on the left you see, yes, your urinary sodium levels go down. Yes, it did impact overall sodium intake. It was measurable. And what you can see is it caused, so these on the right hand side you can see what happened to these outcome measures, and on the left hand side of the line means it decreased. So it decreased 24-hour systolic blood pressure, which was their primary endpoint. It decreased daytime systolic. In the office systolic blood pressure, it didn't really do much to nighttime systolic blood pressure. It did decrease 24-hour ambulatory diastolic blood pressure, daytime diastolic blood pressure, office diastolic blood pressure, but not necessarily nighttime diastolic blood pressure. So it does reduce 24-hour and daytime systolic and diastolic blood pressure to switch from high to low sodium oxybate. Doesn't mean everyone taking high sodium oxybate is going to like have high blood pressure. It just means it's not nothing in terms of what it's doing. So disturbed nighttime sleep and excessive daytime sleepiness are all specifically associated with elevated cardiovascular disease risk. Pathways could include overlapping sleep disorders themselves, autonomic dysfunction, metabolic dysfunction, mental health, and problematic medications. And so here's a great figure from another paper that came out recently that sort of shows all these different pathways. And so I just so showing that there's a lot of different paths. It's not just that narcolepsy itself increases cardiovascular risk, it does it through these different pathways. And so when we're understanding the context of sleep health, and I know I've blazed through a lot of this stuff, but I want to have enough time for questions, but I want to end talking about more bigger picture and directional things. So here's our social ecological model of sleep health. So you have a sleeping person, and these are the health outcomes from the very beginning, from the first slide, that sleep is related to. What is it that drives sleep in an individual person? I mean, there's their genetics, there's their demographics and who they are, there's their thoughts, their feelings, their behaviors. All of these things that exist within the person drive that person's individual sleep-related behaviors and physiology. But remember, these are embedded within a social level. And people with narcolepsy will tell you all about this, that part of your ability to sleep and where you're sleeping and how you're sleeping is partially dictated by things like where you live. What's your occupation? Do you have that sort of flexibility? What's your work schedule? What's your family support system? What are your cultural contexts? What are your social networks, your socioeconomics, and your feelings of safety, things that exist outside of you, but you're a part of? And these are even embedded within a societal level, things like globalization, 24/7 society, technology, racism, climate change, um, you know, politics. These things that exist outside of your work and your neighborhood will drive sleep. And so understanding how all these things go together will help us develop better strategies. So just telling people, well, you could just fix your problem on your own, like that's why it doesn't work because of these contexts are important. And it doesn't mean that you have to solve climate change to help someone sleep better. But what it means is if you could understand more about that person's individual context, you can understand more about how to actually help them. And when I had the artist draw this image for the paper, I told them to draw a sun in the background and make it unclear whether that sun was rising or setting. And that was to illustrate the circadian processes that are happening, all over the body and in all of these contexts that aren't sleep, that are circadian. And those are also impacting health and all of these other processes in the background. I do also want to mention another model that we've been studying in our group called the Mind After Midnight. So here's a link to this paper is freely accessible to download from everybody. It's open access. That spells out sort of our thinking on this hypothesis. And the idea is, so this is something that when you're awake, but your body wants to be asleep, what happens? What is it that is happening, for example, in the middle of the night when you're awake and your body wants to be asleep, when you're not thinking and you're not your best self? Like, why is it that all kinds of unhealthy behaviors will happen during that time? And it's a particular time of vulnerability. And, you know, people who have these periods of awake at night can be at increased risk for everything from unhealthy eating to suicide risk in the middle of the night. So it's important to look at. I just wanted to throw this out there and happy to answer questions about it. So coming back to narcolepsy, what do we do? So here's a study that just came out looking at an exercise program for people with narcolepsy who are sort of tired and having a hard time getting moving. And in a pilot study of 30 people, 6 weeks of supervised exercise training 3 times a week, and then 18 weeks of self-directed exercise training with motivational calls. What happened? Well, at six, so this is after 6 weeks and then after 6 months. After 6 weeks, their narcolepsy symptoms improved. After 6 weeks, insomnia symptoms improved. After 6 months, anxiety symptoms improved. Um, After 6 months, depression symptoms improved. Also, their cardiovascular health improved. Triglycerides and insulin resistance, it only took 6 weeks and they were maintained at 6 months. Cardiovascular risk overall, 6 months later, still improved. Um, their fitness got a little bit better when they were exercising, but yeah, it looks like it trailed off after 6 months. And sort of mental functioning improved at 6 weeks and 6 months, showing that you can have a tailored exercise program for narcolepsy and it works. Not only does it improve their symptoms, it improves the related problems as well and cardiovascular health. Just throwing this out there. So this was a paper that also came out very recently from the American Heart Association, talking about cardiovascular risk in people with narcolepsy. And so what were their recommendations? Um, First of all, this is a figure from the paper, just reiterating the stuff that I've already said. That people with narcolepsy, this is for the American Heart Association. So this is stuff you guys already know, but the AHA doesn't members don't know. This is for cardiologists. Like narcolepsy is associated with higher prevalence of cardiovascular disease and increased risk of cardiovascular outcomes. And narcolepsy treatments, like I was talking about, were associated with some cardiovascular issues. So, what were the official recommendations of the American Heart Association around narcolepsy? Recommendation one, sorry, there's a lot of words on the slide. I should have broken it apart. Recommendation one to the AHA is recognize the risk of hypertension and cardiovascular and cardiometabolic disease in patients with narcolepsy. Consider that it's been linked to increased cardiovascular risk. recognize that patients with narcolepsy might have other sleep disorders, which also increase risk. In patients with narcolepsy without cardiovascular disease, monitor their blood pressure, weight, and waist circumference for adiposity. Implement guideline recommendations for screening for lipids and HbA1c for metabolism. And in the settings of conditions such as hypertension, family history of premature cardiovascular disease, diabetes, glucose intolerance, obesity, metabolic syndrome, and sleep apnea, initiate earlier or more frequent monitoring of people who have narcolepsy. So their recommendation one is recognize that people with narcolepsy have elevated cardiovascular risk. So know that, look for it, monitor it, be aware. That's their first recommendation, which is actually a big change from the past, which is narcolepsy is a sleep disorder, not a cardiovascular issue. This is saying narcolepsy is a cardiovascular issue. Recommendation number two, reduce the risk of hypertension and cardiovascular and cardiometabolic disease in people with narcolepsy. Number one, talk to patients about this connection. Number two, go look at Life's Essential 8. Go back to Life's Essential 8 and go to those guidelines. Improve what you can across all of Life's Essential 8, including exercise, quitting smoking, improving dietary health. Do that for people with narcolepsy. Number three, evaluate and treat other conditions that are often overlap with narcolepsy that you can't forget about, especially sleep apnea, which is a major cardiovascular risk factor and is very common in narcolepsy, and also tailor the narcolepsy medications on the basis of this cardiovascular risk. That is a big, so not a lot of words on the slide, but that's a big deal in terms of changing how treatment of narcolepsy should exist, because instead of just treating the narcolepsy, the AHA says when you're treating narcolepsy, don't forget about if you're dealing with a patient who has high cardiovascular risk, be aware of what medications they're taking and how that impacts that cardiovascular risk. And then number three, a whole separate recommendation about sodium. The American Heart Association is all over the sodium issue. And it says educate patients about sodium intake and how that relates to high blood pressure and cardiovascular disease, like I've been talking about just now. Advise patients that reductions in sodium might lower blood pressure and cardiovascular risk. Provide educational materials like AHA guidelines and whatever to help people reduce sodium intake, and advise patients to use salt substitutes and implement low sodium diets, especially if they're using higher sodium oxybates to treat their narcolepsy, which can be very effective and helpful. But if you're going to do that, try and counter it by reducing sodium. So those are the recommendations of the American Heart Association, which I support. And so then a little bit more about like sort of what to do. So there's going to be lots of stuff about sleep hygiene. So we did a study recently asking people with excessive sleepiness, what do they think is going to improve their sleepiness during the day? And a lot of them said, well, if I can get some better sleep at night, that'll help. And to some degree, that's true. But a lot of people think sleep hygiene is going to fix all their sleep problems, and it's not. It rarely cures insomnia. It's not even a core component of insomnia treatment. And a lot of people try this stuff and then give up. And a lot of these rules aren't even always true. So it's like, we treat them like they're the 10 commandments of sleep. They are the rules written in stone. If you don't do all this stuff around your sleep is going to be awful and bad. And the truth is, they're the fake 10 commandments. They're the movie poster 10 commandments. They're written in styrofoam. They're just recommendations. They're not delivered from on high. So I apologize for my irreverence there, but like, we treat them as if they're these things you can't deviate from, but really they are. So, a little bit joking with that in mind. So what are the 10 sleep hygiene commandments that are mostly true, but don't always apply, especially to patients with narcolepsy? Like, thou shalt keep a regular schedule, clap of thunder. Yes, keeping a regular schedule will help. Regularity is important. Building regularity where you can will help, but it doesn't mean you have to keep it totally regular all the time. Exercise regularly, but not too late at night. Getting physical activity is good. It's good for sleep, especially for patients who are sleepy with narcolepsy. If you have to do it in the evening time, and it doesn't impair your ability to sleep, don't worry about it. Actually, the risks of exercise at night are mostly overblown. Get light during the day. Avoid light at night. That will help build that regularity. Keep your bedroom cool, dark, quiet, and comfortable. Not rocket science. Don't consume excessive foods or liquids in the evening unless you want to have to get up to pee more at night. And you want more reflux at night. Try to avoid more heavier foods and liquids in the evening. Plus, the food you're eating, all the time restricted eating data shows that what you're eating closer to bedtime is more likely to be related to weight gain than actual energy your body needs. Try to put down screens for getting ready for bed. Not this isn't always doable for people, but if you can at least tone down the content and the activation from those screens, that would be better. Caffeine, nicotine, and alcohol at night. All of these will make sleep worse. Don't go to bed angry, worried, or upset. Be angry, worried, or upset. I kind of don't care. Just don't do it in bed. Don't make the bed the place where all this happens. I'll talk about why in a minute. Get rid of the clock. I'm not saying you have to get rid of the clock. This is a recommendation that I think is also a little bit overblown. Lots of people have clocks in their room and don't have a problem with it. But people who obsess over the clock, maybe turn it around, maybe make it harder to see. Because often, if you wake up during the night and you need to get back to sleep, just go back to sleep. If set an alarm if you need to wake up. If the alarm's not going off, just go back to sleep. Don't worry about it. Some people obsess over the clock and it makes things worse. And then finally, I put this on for you guys. Thou shalt not nap too long or too late during the day. A lot of people tell you to not nap and that napping is bad. Napping is good, especially for patients with narcolepsy. Controlled napping, napping on purpose, can be a great way to improve functioning during the day. Don't let people tell you otherwise. If anything, maybe talk to your sleep doctor about getting a workplace accommodation letter to be able to nap during the day. That might dramatically improve safety and performance. So this is a recommendation that I think is wrong for people with narcolepsy. Um, a lot of people with insomnia have trouble turning their mind off, and they don't know why. It's because of these perpetuating factors that that lead to this programming of your brain to be awake in bed. What happens is, for one reason or another, something caused you to spend time awake in bed, especially if you're struggling and up and down a lot during the night. Now, I know a lot of people with narcolepsy, this is not their problem, and for a lot of them, it is. When your original cause of this sleep disruption is gone, an insomnia can take on a life of its own. So you need to give yourself, if you're having trouble, if you want to prevent this from happening, if you find I get into bed and my mind just won't turn off, you know, budget enough of a wind down time for this. And both mental and physical, and or else you get to this issue where people say, my mind just keeps going when I get into bed and I want it to stop. To me, that's like saying my car just keeps going when I get in the intersection, but I want it to stop at the stop sign. And the question is, how fast were you going, and when did you start pressing the brakes? And if you said I was going 100 miles an hour and I started tapping the brakes 2 millimeters before the stop sign, well, no wonder why your car's still in the intersection. You need to give yourself this time to wind down. And a way to understand how sleep problems build during the night, use the 3P model, the Spielman model is really helpful. So I mean, this is for insomnia, but I think it relates in general to sleep health. So you have these predisposing factors. These are things you can't control. They don't really change much over time. You have the precipitants. These are the things that cause your sleep to be disrupted. And they fade over time by nature. Sometimes they never fully go away, like you see in this image. But the key is the perpetuating factors, the things that didn't exist when your insomnia first started, but they take on a life of their own. And the treatment actually focuses on reducing these. A lot of these have to do with staying in bed and fighting sleep. If again, a lot of people with narcolepsy, this isn't their issue, but there's a lot of people for whom it is, that they're up and down during the night and it's stressful, or they had a nightmare or whatever that caused an activation during the night, and then they're trying to get back to sleep. The key perpetuating factor that makes sleep quality worse over time is effort. The enemy of sleep is effort. The more effort you're putting in to get back to sleep, it's going to backfire and create activation and psychophysiologic activation that's going to make sleep harder. Sometimes wakefulness is what you need to be able to take the time you and space you need to get back to sleep. If you had a distressing dream or a respiratory arousal or something during the night and you have this activation, you have to wait for it to settle back down. Think of a snow globe that was shaken up. You got to let it settle back down. Trying to force it is just going to make it harder. More is less. Effort is what backfires. And engaging in effort when you're trying to sleep is actually what will cause more of these long-term problems. Um, so take home messages, and then we've got some time for questions. Build as much regularity into your sleep schedule as possible. Remove major barriers to being able to wind down. Get into bed when you think sleep is possible. Keep your bedroom cool, dark, quiet, and comfortable. Have a good wind down routine. Have a good morning routine to help wake you up and get some bright light in the morning. That will help your energy level during the day. If you have more occasional sleep issues, now, and I mean separate from narcolepsy, like if you're treated and managed and things are working okay, then you're fine. But if you're still struggling with all the treatment, everything that's going on, reduce your activation at night. Maybe through relaxation and meditation, maybe through reducing screen use or using blue blocking lenses, or dimming the screen. Consider tracking sleep and using information. Maybe some supplements and other strategies can address more mild sleep problems to take some of that edge off. If you have more moderate or frequent sleep issues beyond your treatment for narcolepsy, get out of bed if you can't sleep. That's the first thing I'll tell you. If only stay awake in bed about 20 to 30 minutes at the maximum. This will protect against future sleep problems. If you need help getting back to sleep from some of these awakenings, I don't know, keep a notepad or something by your bed to download your thoughts so that you don't have to sit there with them. And if you're not able to sleep, don't try harder. No one got to sleep faster by trying harder. And if you have sleep apnea or another sleep disorder, get it checked out and treat it. If you have insomnia, CBTI will help. If you have sleep apnea, get it treated because those arousals and awakenings could be making things worse. So thanks. Hopefully we have some good time for questions, and we'll go from there.
It looks like we do have some questions in the Q&A, and I know there's a question in the chat about, is this the same for IH? Does all of the information apply to IH, or would it be different?
Pretty much. I mean, there's just a lot less. I mean, it's an open question. It doesn't seem to be much functionally different, except the pieces that have to do with orexin. The parts that have to do with sleep disturbance sometimes apply. Sometimes when people with IH don't have nighttime sleep disturbance, sometimes they do. Um, to whatever degree any of these concepts apply to IH patients, they should apply. I didn't focus on IH mostly because there's not a lot out there, but the treatments are sort of the same. The risks may be sort of the same, except for the orexin piece is sort of unknown. But but yeah, I mean, I would say in general, I would guess that a lot of this applies, even though IH hasn't been studied in as much detail. Um, Let's see. Okay, so and I also see in the chat, um, let's see. Um, is it okay? That's just that one. Okay, so in the Q&A, the first question is about POTS. So I don't know much about POTS, not as a cardiologist. So POTS is postural orthostatic tachycardia syndrome. Um, so it has to do with, I think, sudden changes in heart rate. If one has POTS, one of the treatments is to increase sodium. How do you reconcile this with sodium already taking sodium oxybate or even more sodium in your system? So, um, I don't know much about POTS. I think part of what sodium does is it increases blood pressure by retaining water. Um, I don't know. That might be more of a cardiologist question about how sodium is related to POTS. Sorry. Um, but this brings up another important issue where most of the data around any of these sorts of treatments are usually in isolation. So what we know about sodium and POTS, I doubt there were any sleep disorders patients or much less any sleep questions asked in any of those studies. So how does it relate to the treatment? I don't think that there's much known about how these treatments relate to each other, especially things outside of sleep, how they relate to treatments within sleep. I think a cardiologist will be like, well, we know about this in isolation. We don't know about the combination, and it'll be mostly guesswork, in which case, it might require some experimentation. Next question on here. How often should people with narcolepsy have their blood pressure and heart health monitored? I think the recommendation is at least annually. Um, but maybe if there's a risk, it might be more frequently. at least at every visit. Though it's important, so something that's important to note: blood pressure taken at a clinic visit is not great. Um, it's very situational, and that's why the oxybate study I was talking about, it was 24-hour blood pressure, where they get your blood pressure across the day because it changes across the day. And it's different at home versus in a lab versus in a doctor's office. So, it's hard to evaluate blood pressure out of a lab, but if you have a concern, it might be worth getting some sort of ambulatory measure where you're measured across 24 hours. But I think I don't remember exactly what the recommendation said, but I think it's at least annually, just to be sure. And the good thing is, if your blood pressure goes up, it doesn't mean you're going to have any kind of negative outcome now. It's more of a buildup over years, and so keeping an eye on it's important. If you switch to a lower sodium medicine, then you get to the medicine that has sugar added in. Is that really any better? That's a good question. I don't think there's any data on that. Um, then maybe 10 years from now we'll have a question about high sugar versus low sugar medications. So I don't know. I mean, I don't know exactly how much sugar is added and whether that is relative to the amount of sodium added. Certainly more sugar is not better, especially taking sugar in at night. So, it's sort of like I was saying before with the soda. Like that's why I'm not trashing sodium oxybate either, where it's that I mean it's sort of easy to throw under the bus, but if it's significantly helping you and that help is creating a net benefit, um, maybe it's worth it. I'm not saying it isn't worth it. And so again, if this is helping more than it's hurting, then it's probably worth doing. But it also means that we still have a lot to learn, and there's still a lot of research we need to do. Because like I don't know. I mean, if some and we can like maybe people taking those, maybe they should be monitoring their blood sugar and see if that significantly changes. Then so does sodium oxybate mask insomnia? That's an interesting question. Um, I don't know. It could for sure. I mean, or it could fix insomnia. Who knows? There hasn't really been much in terms of studying sodium oxybate in insomnia, mostly because the FDA would never approve it for insomnia, even if the data were strong. So I don't know. It may. I mean, it may forget masking. It may steamroll over your insomnia as well. Um, Okay, so that's all we had in the Q&A. Any other questions want to pop in? Well, we still have a couple. Sorry, I sort of rapid fire stuff. Um, but so I'll talk a little bit as in terms of other questions that might come in. And I don't know if anyone wants to add any. But another thing that I wanted to mention is a lot of people with narcolepsy. Um, First of all, they're getting seen by sleep medicine, but a lot of times they don't get seen by behavioral sleep medicine, which is more my area. And so I think it's important to know that behavioral sleep medicine does have something to offer our hypersomnia and narcolepsy patients. We don't administer the medications, that's sleep medicine. But there's two benefits to seeing someone within behavioral sleep medicine. Number one is we're usually trained in mental health, and all of those questions that your sleep medicine doc does not want to ask you about depression and anxiety and stress, and if they do ask, they just sort of jot it down. We actually have strategies for helping with that and scheduling naps and dealing with some of the stress and managing. The other thing with behavioral sleep medicine is we usually see people every week or every week, not every 6 months. So we get more touch points with people. And so I would encourage people who are struggling to reach out to, in addition to sleep medicine, seek someone out in behavioral sleep medicine. We can definitely help. And the Society of Behavioral Sleep Medicine has been very interested in finding new ways to help people with narcolepsy. And there's a CBT for narcolepsy, and there's a CBT for hypersomnia. I mean, there are things that we can do. Okay, a few more questions popping up in the chat. Number one, what warning signs should patients watch out for that might indicate medication-related cardiovascular strain? That is a good question. I wish I were a cardiologist and could answer a little more detail. I mean, it sounds like this is more of a question for Viren Summers, but um, I would say look for changes when you get your annual blood work. get annual, check your blood pressure annually. And if you see an inflection point where things start drifting up for a couple years in a row, that I think would be more of a warning sign than anything else. I don't think you're looking necessarily at cardiac output. I think you're going to see those inflection points in HbA1c, blood pressure, lipids. You'll see those inflection points years before you're going to see like cardiac strain. I think that's what I think is going to be more typical. Next question. Question about sugar and meds. Xywav has artificial sweeteners in it. How does that affect cardiovascular health? Yeah, I mean, there's also data showing that artificial sweeteners aren't great either, that they can increase weight. So there's actually data showing that artificial sweeteners can increase weight gain and change dietary cravings and make it difficult to maintain a healthy diet. So yeah, like again, weighing risks and benefits and showing that we still need continuous improvement. What we got, the solutions we have can be great, but maybe the next solutions we can have might be even better. How does stimulant medications for narcolepsy affect long-term heart health? Yeah, I mean, that's what I talked about near the beginning. Stimulants increase heart rate. They can increase cardiac events. There's a reason why long-term use of stimulants is associated with more cardiovascular disease. Generally, with the exception maybe of caffeine, but that might just be because coffee has also lots of antioxidants and phenols in it that might be good for heart health. But long-term use of stimulants is associated with increased heart disease and arrhythmias in particular. So it's definitely something to watch out for. And so that's why most people who are on chronic use of stimulants, their doctors already know to do EKGs and monitor these things. And if they're not, they should. Um, with long-term use of sodium oxybate, stimulants, or other medications that can impact the heart, do you think this will have an impact on how narcolepsy is treated in geriatric patients, given the risk of stroke and heart attack tend to increase with age? Actually, this is a great question in that this is what we see in insomnia as well. It's the same thing, where in insomnia, the medications most used to treat insomnia are things like sedatives, which are things you do not want to give older patients because they increase fall risk, memory problems, dementia risks, etc. So the treatments that are most often used are the ones you most want to avoid in older people, which has driven the discussion of alternative treatments. I mean, CBTI should be first line anyway for any age, but for people who don't have access to CBTI, this is where the discussion of the dual orexin receptor antagonists are coming in for insomnia, but that's a different discussion, not narcolepsy related. But similarly, if these medications might increase risks, then maybe that might change how people prescribe, and that might also hopefully drive some innovation in the space to try and develop strategies that are less harmful. But then on the other end, if someone is otherwise healthy, and it takes 20 to 30 years for increased sodium intake to cause heart disease, maybe, you know, if someone's already 70 years old, maybe the reduction in risk, well, people aren't going to get new narcolepsy diagnoses when they're older, like unlike insomnia. But if you're starting new medications when people are older, it might be worth taking them off of stuff that's increasing risk. But also, if they're already at high risk, increasing the risk, maybe they've ceilinged out and they're already at high risk, and switching them off at this point might not make a difference. I don't know enough about that physiology to know the answer, but I think it's a complicated question because there's the dynamics of time, where if you're already at high risk, switching people off might not necessarily reduce risk. That's actually an open question. That which was answered by that sodium oxybate study of high sodium to low sodium in the short term did decrease risk, but we don't know what happens with some of the other medications. And one last question on here, because we're at time. If you have sleep apnea on highest dose of sodium oxybate, it would be wise for me not to stay on long term because long-term heart health. Also PLMD, RBD, RLS. Sounds like, I mean, not talking about it, can't talk about an individual case. Um, yeah, here's somebody who's got a lot of these conditions where they're potentially monitoring 24-hour blood pressure every 3 months. Maybe an answer to the question of somebody who, like, what do you recommend? Yeah, quarterly, especially with all this going on, things can change. It's important to monitor. And when you have lots of comorbidities, it definitely makes things complicated because these things can feed each other. Um, but yeah, all right. So that seems to be all the questions we have, and we're at time. Thank you so much. Thanks, everybody. And I am happy to help where I can. Thanks so much to Wake Up Narcolepsy. What a great patient community. And sleep is related to heart, and narcolepsy is related to heart. And let's get there together. Let's do what we can.